Hi, I'm Professor Stephen Alder, Executive Director of the Center for Business, Health, and Prosperity at the University of Utah, and one of the project leaders for the Health and Economic Recovery Outreach, or HERO project. We're pleased to welcome you today to this session where we'll describe what we've been up to over the last several months, where we are in terms of our understanding of the pandemic based on the work of the HERO project, as well as input from some of our partner organizations and what we can look to for the future. Next slide, please. We have not been able to do this important work of helping to monitor and understand the impacts of the COVID-19 pandemic without many collaborators, several of which are listed here. Most notably, we'd like to thank the support of the David Eccles School of Business, University of Utah Health, and Associated Research and University pathologists. We'd also like to thank our partners, next slide please, who have also helped us throughout the community, including public health agencies throughout Utah and other organizations which have provided essential support to assure that we're able to do the work that we have been tasked to do. Next slide, please. You'll note that in the chat box, you will be able to submit questions. At the end of our session, we will have a period of time where we will have a question and answer portion of the presentation. So please, if you have questions along the way, please submit those. We'll be monitoring those and we'll be able to respond to as many of those as time permits. Next slide. The Utah Health and Economic Recovery Outreach Project has been something that has been in place now since April of 2020. Initially, this project was designed to look at community-based circulation of the SARS-CoV-2 virus, the virus that causes COVID-19. Since that time, we have also expanded our efforts to look at other elements of the pandemic, many of which we'll focus on today. Those include how has the pandemic impacted our schools and what have we learned about the impact of the pandemic on school activities? How about the interplay between the pandemic and economics and the economic activities within our state? And finally, as we all know, vaccines have become a topic of great interest, and hopefully that element which will help us to resolve the pandemic so we can get to the new normal. And so we'll spend some time discussing what that may mean for Utah. Next slide, please. I'm privileged to be accompanied by several of the leaders of the HERO project who will be presenting today, many of whom are accomplished and internationally renowned for their work. Next slide, please. Each of them will take a topic with which they have deep expertise and understanding and will provide updates that will help us understand once again where we are and where we may be going with the pandemic from the perspective of the Utah HERO project. And so to start, I'd like to introduce our first presenter, Dr. Matthew Seymour. Matt?
Thank you, Steve. It's such a pleasure to speak in this webinar, and I look forward to the questions. Next slide. I'm going to discuss the community surveillance component of the HERO project. I will briefly review our initial findings from the spring and summer, and then I will show you results from the fall until the present, focusing on geographic variation, age-specific seroprevalence, PCR positivity, trends, and then we'll conclude with a discussion of the implication and interpretation of these results, particularly with respect to how well we're doing to detect detect COVID-19 infection in the state of Utah, and also to help us understand what may be the reason for declining infection rates in the state since the new year. Next slide. So this slide summarizes what we found in the spring and the summer. So first of all, PCR positivity was extraordinarily rare. I should add that the basic approach for our community surveillance was to invite participation of randomly selected households in Utah communities. And we asked the participants to complete a survey, and then they came to a testing site for a blood draw or dried blood, a finger stick or dried blood spot if they were less than 12. That was for serum antibody, and they also underwent or submitted a sample for SARS-CoV-2 PCR testing, which was initially a nasopharyngeal swab and then switched to saliva. Now, serology is informative about cumulative past infection, but it's not perfect because the test may have false positive or false negative, and antibody tests may decline with time after infection. The PCR prevalence is a measure of the new infections. However, it's not a perfect indicator of infectiousness, since some individuals remain PCR positive for some time after infection. Now, as I mentioned, the PCR positivity was extremely low, and seroprevalence, the prevalence of antibodies to SARS-CoV-2 was also low. Even by midsummer or late summer, it was less than 2% in Utah communities. When we first started in April and May, in May and June, we found a seroprevalence less than 1%. And this was similar across all the counties that we tested, focusing initially on the Wasatch Front, but then extending to other counties in Utah. And the only exception to this was Summit County, which had experienced an early outbreak of SARS-CoV-2 infection, of COVID-19 infection in the spring. We found that seroprevalence was associated with the ethnicity, the self-reported Hispanic, but not associated with age. And we also estimated that the detection fraction was about 42%. And this translates to 1.4 undetected COVID-19 infections for every detected case. This is a very high detection fraction relative to other states in the US and other countries. So this was felt to be a success story for public health detection and reporting of COVID-19 infection. Next slide. But then autumn came. And so when we retested Utah communities in the fall, we found a different story. Next slide. We found that, for example, in this comparison, I'm showing results of serology in Provo in Utah County and West Salt Lake in Salt Lake County. And you see two striking differences or changes. One is that the seropositivity was much higher in Provo than in West Salt Lake, and this was true across the board in communities that we tested in Utah County compared to Salt Lake County. And you also see a very striking new change in distribution by age, with the highest seroprevalence in teenagers and younger adults. This pattern was similar in West Salt Lake and Provo, but more exaggerated, more pronounced in Provo, this age-specific pattern. Next slide. Now, when we show the PCR data for this corresponding sample of participants in Provo and West Salt Lake, you see a similar pattern. But you see how much PCR positivity has increased compared to in the spring and summer. Now, in the teenagers in Provo, up to 4.6%. So this is showing and this is consistent with, the high levels of infection, high levels of infectiousness in the population. Next slide. Now, in December, when we retested communities in Salt Lake County, we found that Salt Lake was catching up to Utah County, and it was having a similar level of seroprevalence for young adults and teenagers. When we retested in January, we found a different story. And for the first time in January of 2021, we see a very high seroprevalence for Euroimmune tests compared to the Abbott test. We were using two different tests to support a kind of better approximation of the true antibody status of the population, because these tests have different test characteristics, different levels of false positive and false negative. But also these tests detect antibodies to different antigens. The Euroimmune test detects antibody to the spike protein, whereas the Abbott test detects antibody to the nucleocapsid antigen. And the importantly, the vaccine is of the spike protein, and so that the elevation of Euroimmune seroprevalence compared to Abbott is reflecting a combination of natural immunity and vaccine-induced immunity, whereas the Abbott test is only reflecting natural immunity. And so now in January, we can start to dissect how much of the immunity in the population is due to vaccination versus natural infection. And in our participants in January, we found about 10% reported receipt of at least one dose of vaccine. Next slide. And what we see in unvaccinated individuals now extending into early February is again higher, even higher, seroprevalence, now up to 10% for Salt Lake County, but a little bit lower PCR positivity, down to 1%, but still much higher than it was in the spring and early summer. Next slide. So what does this translate to in terms of our estimation of detection fraction? Well, we use several different approaches to estimate the detection fraction. We compare seroprevalence to cumulative case reporting, trying to account for the test sensitivity and account for declining antibody levels over time. And we also looked at the fraction of seropositive individuals who reported having had a prior positive COVID test. And by both methods, rather than detecting, or rather than finding that the detection fraction was going down during the worst part of the surge in the fall and the winter, we found that the detection fraction was actually going up. And what we think is that this reflects the intensive testing and very strong access to testing in the state of Utah. So our current estimates are that there's less than one undetected case for every detected case. And for example, in our January to February data, 62% of the individuals who had a positive Abbott serology, which is the antibody that reflects natural infection, 62% of those individuals reported a prior positive COVID test. And so the consistency between our different approaches to estimating the detection fraction gives us some confidence that that there is not a reason for detecting a high or estimating a high detection fraction due to bias or other confounding. So we think this is an accurate estimate for the state of Utah. Next slide. Now, what we're also seeing though is that there is some evidence of variation in the detection fraction across different age ranges. So in the age less than 12, as low as 15% detection fraction, or at least 15% who's self-reported prior positive COVID tests, compared to up to 76% of individuals whose were seropositive reported as a positive COVID test in the past. So some evidence of age variation in the detection of COVID-19 infection. Next slide. So the interpretation is that Utah is continuing to do well in terms of detecting COVID-19 infection. There's an evidence of an age gradient, and as I mentioned, there's evidence that the detection fraction actually declined even as incidents surged. By the end of January, we estimate that 22 to 28% of residents of Salt Lake County had either experienced natural infection or had been vaccinated or both. We see a lot of variation across age groups in seroprevalence and PCR positivity, and we're starting to explore some of the factors that may be associated with community and household transmission. We previously have analyzed household transmission and found a great deal of heterogeneity, of diversity, and infectiousness of individuals within households. What we're seeing now is that, that at least based on our self-reported data, that self-report of going to eat inside a restaurant was associated with seropositivity. That analysis of these factors is ongoing. And then finally, we attribute the decline in infection rates to a combination of the depletion of susceptibles from natural immunity and vaccination and continued use of social distancing measures, combined with intensive testing to detect cases for isolation and quarantine of contacts. And I should add that, next slide, that one reason why the depletion of susceptibles, even at 22 to 28% immunity may have an impact is that the estimated real-time reproductive number, this is a slide a graph generated by one of our faculty, Dr. Yui Zhang, shows that even during the worst part of the surges in the fall and the winter, the reproductive number in Utah never exceeded 1.5. So the critical threshold for the reproductive number is 1. You see that it declined below 1 at the beginning of the new year. And you see that even during the November-December period, that it was still less than 1.5. So the amount of gain that needed to be achieved to control and bring the reproductive number less than 1 was such that even 20 to 30% of residents being immune would have an impact. And with that, I will shift and hand the baton to Dr. Adam Hirsch, who will speak about schools, and also Ben Horsley. Thank you.
Thanks, Matt. While talking about our larger communities, schools are certainly a very important part of our larger communities. Once schools opened at the end of the summer in Utah, it became apparent to the leaders of the HERO Project that developing an understanding of school-based transmission for COVID was essential to keeping our schools open and safe. And our team was well equipped to contribute to these efforts. Another thing we learned from the summer was that we had seen that transmission among school-age children in congregate settings could potentially be rampant based on experiences we observed from households, daycare centers, summer camps, and the like. The question that emerged was, would schools look the same, or would the mitigation strategies put in place keep transmission to a minimum? You can go to the next slide. So the objectives of the HERO School Project are as follows: number one, to understand COVID transmission patterns in schools, to develop testing strategies to mitigate outbreaks, and to adapt school policies to maximize opportunities for in-person learning. Our work ultimately is focused on two key questions. First, is in-person learning associated with higher COVID incidence than remote learning? And second, how often does COVID spread in schools after an initial infection is introduced into a classroom? Next slide. So for the first question about in-person versus remote learning, next slide. This map shows the distribution of the percentage of public schools by state in the US offering in-person learning currently as of this month, February. States that are shaded darker indicate a higher percentage of in-person learning, including Utah, which is now basically at 100%. Notably, at the start of the school year, fewer than 40% of US public schools were offering in-person learning. This has fortunately increased to over 60% nationwide. However, there still remains a large number of students throughout the US in remote learning only. Next slide. These graphs here show trends in case counts for school-age children in Utah in 3 different age bands. The main take-home point here is that there was a major surge in the fall across all age groups, immediately following after school opening statewide. To better understand to what extent this fall surge might have been driven by in-person learning, we took advantage of the fact that in one of our counties, Salt Lake County, we had 4 districts that began in-person learning, and 1 district, Salt Lake City School District, that did not and remained in remote. Next slide. So to do this, we compared COVID incidents in students residing in Salt Lake City School District to the incidents in students residing in the other 4 districts taken together and combined from the beginning of the school year up through November. So this graph will show us the relative risk and incidence for the 4 in-person districts versus the neighboring remote district. The relative risk is a ratio calculated by dividing the incidence among students in the in-person districts by the incidence in the remote district. A relative risk of 1.0 would indicate no risk for in-person learning compared to remote learning, whereas a relative risk above 1.0, which is on the right part of the graph, would mean there's a higher risk for in-person learning. And a relative risk below 1.0 would mean a lower risk for in-person learning. Next slide. Overall, across all ages, the relative risk for the in-person districts compared to the 1 remote district was 1.18, indicating an 18% higher risk of COVID associated with residing in an in-person district. However, the story really changes when it's broken down by grade levels and comparing the risks between districts for elementary, middle, and high school ages separately. Go to the next slide. So the relative risk for elementary school ages, which is at the top of the graph, and middle school ages, which is in the middle, are very close to 1.0, with confidence intervals indicating that there was essentially no difference in their incidence between the in-person districts and the remote district. On the other hand, the relative risk for in-person learning in high school was 1.61, indicating that the risk was 61% higher for high school age students residing in the in-person districts compared to the neighboring remote district. Now, this was a fairly striking finding and raised a number of questions for our team about where the excess risks for high school students were occurring. Was it related to actually physically attending and being in the building, so to speak? Or was it more related to activities around school, including things perhaps like transportation to and from school, or differences in the types of activities that were taking place, social activities taking place outside of school? There's more work to be done here for sure. So now we'll move on to consider the second key question that the HERO project aimed to address. Go to the next slide. How often does COVID spread in our schools once it's introduced? Next slide. Well, to begin to understand COVID transmission in schools, we realized early on in the fall that we needed to greatly expand school-based testing. Beginning in October of 2020, the HERO project expanded its community-based testing efforts that Matt was previously talking about to now provide free, convenient, on-site, at-school PCR testing for school communities. Since this time, we've been able to perform nearly 4,000 tests for nearly 3,000 students, teachers, and staff, representing more than 90 schools in the greater Salt Lake area. Overall, 3.4% of these PCR tests have been positive, with the vast majority among asymptomatic individuals, screening tests. The positivity rate differed significantly between students and teachers, with more students overall being testing positive. Over 5% of students in all of our tests have tested positive, as compared to 2% among teachers and staff. The good news is that this has changed dramatically over time, however. When we began, we routinely had more than 10% of students test positive in schools, most of whom were completely asymptomatic. Whereas now, the asymptomatic positivity rate is as low as 1% to 2% in most instances when we're testing at schools. The importance of this insight to us was that it made clear how often asymptomatic infection was occurring in school-age kids. And this has served to encourage the development of testing strategies statewide that focus on asymptomatic individuals, including our new test to play and test to stay strategies. Next slide. As part of our school-based testing program, we also work specifically to measure spread in elementary school classrooms. Our basic approach was to identify an infected student or teacher who was contagious for at least one day while in school, and then to offer testing to everyone else around them who would have been exposed to that initial infection in school. After testing nearly 1,500 school contacts as part of the HERO project, 1,500 school contacts of a contagious case in school, we detected additional positives in less than 2% of these contacts. And then, after excluding those positives that had a clear-cut out-of-school explanation for their positive test, and also bolstered by genomic sequencing, we've been able to estimate that the chances of in-school spread in our communities are less than 1% under current conditions. One way of thinking about this conceptually would be to imagine if 5 students came to school infected and contagious and entered into 5 different classrooms, each with about 20 students, so a total of 100 students. In 4 out of 5 classes, there would be no spread, and in 1 class, there'd be up to 1 student who became infected due to school exposure with this estimated transmission rate. Now, this low rate of transmission for such a highly transmissible infection is really a testament to the great efforts made by our schools, to teachers, to staff, to administrators, to parents, to students, the list goes on, to ensure high mask compliance, along with all the other important mitigation strategies that are taking place. It's also worth noting that most of the classrooms where we perform testing reflected the real world conditions, these real world conditions that we have here. Classroom sizes were frequently more than 20 students, and spacing was frequently less than the 6 feet recommended by CDC. And these investigations, also of note, were conducted at a time when there was widespread transmission in our community. Next slide. So some conclusions and remaining questions. First, and perhaps foremost, we feel that these data add to the almost weekly growing body of evidence that in-person learning in elementary and probably middle schools as well is safe and should be prioritized nationwide. We've demonstrated that with adherence to mitigation strategies, most notably universal masking, in-school transmission in elementary schools is very infrequent, and large outbreaks due to in-school exposures are simply not occurring as they might have occurred otherwise without mitigation strategies. The explanation for the higher risk of infection in high school students learning in person compared to remote is uncertain, and this certainly requires further investigation. Our collective experience in Utah indicates that testing of asymptomatic individuals in schools is feasible and scalable and provides a valuable complementary surveillance metric for our larger community. And lastly, our experience in Utah suggests that we need to continue to be guided not only by national guidelines, for instance, from CDC, which provide really important foundational principles, but also by our own local data, which in some cases has supported pursuing greater in-person learning opportunities than we might have otherwise. Thank you, and I'm now going to briefly turn it over to Ben Horsley, who's the Director of Communications and Community Outreach with the Granite School District, and the Granite School District has been one of our most important partners. Thank you.
Thank you, sir. Appreciate the transition there. If we go to the next slide real quick, just wanted to briefly talk about some of the adaptations we've made as a result of COVID-19 and kind of give some anecdotal thoughts and ideas with respect to why we see a slight increase with respect to our high school students in particular. Testing obviously is something we're working on and providing additional resources for in a variety of modes. We want to make sure that we look at what we've done and learned since the start of the school year. Increasing testing for not only our students, but also for our staff is a critical component of this as a result of being able to reduce spread, particularly from asymptomatic individuals. So looking at opportunities to increase that testing, we do have regular opportunities through the county health department and are looking for clinic opportunities even run by the district itself. That being said, the HERO project has obviously often offered an extensive amount of opportunities. We continue to broadcast those out to our general public and see pretty good participation in that regard. So we're very pleased with that. In addition to that, Adam mentioned test to stay, test to play, and now what we're working on is test to sway. And I apologize for all the rhyming. It's quite embarrassing, frankly. But what we see is starting with winter sports, in addition to taking regular precautions such as mask wearing, temperature taking, and logging those, watching for symptoms, all those other regular precautions, while the students may have been on the sideline in advance of practice, we were not requiring masks as part of High School Activities Association guidance and health department guidance while they were actually participating in the sport itself. But up until that point, up until winter sports, we did not have any regular testing protocols. So test to play came in about starting with our winter sports, where our athletes were required to test every other week. This is a rapid antigen test. We do that on school property and are able to produce results rather quickly. We have been able to identify a very small number of cases as a result of that, but we still are seeing a very low transmission as a result of our students who participate in these activities. So that's really good news. In addition to that, we saw as a result of the HERO testing that the results of transmission rates were very minimal. And we saw that internally with our own contact tracing, where we were able to confirm pretty strong correlations to where these cases were coming from. As a result of that, we got on board with HERO testing and then the state health officials to identify ways to keep kids in school, because it did appear that universal mask wearing and some of the other mitigation strategies were working. And so we wanted to make sure that these 2-week dismissals as originally envisioned were minimized. And as a result of some of the testing results that we're seeing here, some of this data and some other data, the state changed the model for those protocols back in December, starting with this new year, and is actually, we're seeing some additional push to modify those further. What that means is that when we started the school year, if you got up to 15 cases within your school community, there was a recommendation from the health department to dismiss the school to distance learning for a 2-week period. That's just kind of give everybody a rest. There wasn't a requirement to quarantine, though. This was just, we're not going to be in the school building anymore with that particular group or community. We saw dozens of these, mostly at the high school level in Granite School District. I know some other school districts experienced this at the elementary and junior high. We did not have that circumstance. Starting in January, that model got changed. Any school district, any school that was over 1,500 students was able to go up to a 1% case threshold before dismissal. Anybody below that was still on that 15 count case. So we've actually seen very few dismissals, but now we've also implemented test to stay, wherein as we reach those thresholds, we'll come in and do rapid antigen testing of the entire student population, at least those who are willing to participate. We've seen high rates of participation, but very low rates of actual case counts. Let me give you an example. Skyline High, their last test to stay, 0 cases out of a test to stay protocol. Its neighboring school, 4 cases, and the neighboring school beyond that, 6 cases. This is out of thousands of tests. So again, very low rates of transmission. Getting on to the other 2 items really quick, vaccination clinics have been ongoing since the start of the year. We've been very fortunate to get teachers prioritized as part of that process. Today is actually our vaccine day. If you walk down to one of our school buildings, we're actually in the process of administering second doses, and we anticipate being done with that by next week. So that has actually shown a sharp decline in cases on school property. We're very pleased with that. Mask wearing, everybody thought last fall that masks would be very challenging to wear, that students would not follow that protocol very well. Students have been marvelous. They've done a wonderful job of wearing their masks on school property. Wearing masks off of school property, not so much. We do see a lot of students who get in their cars with their little group, and as soon as they hit the boundary to leave the school for the day, the masks come off. And that's very anecdotal, but it might contribute to the fact that these students are being safe on school property, but not following those guidance off of school property. That might be attributable to the higher rates at the high school level. We see those high school students interacting and socializing at a higher rate than our junior high and our elementary students as well, especially off of campus. I would say that with obviously we've seen some opportunities to increase innovation and school choice as a result of the pandemic. There are some silver linings to enhancing our distance learning options, expanding Wi-Fi access and technology, especially to our high poverty families, and looking at different ways we can approach programs. So things have been going quite well, and you may have heard just yesterday that we've been given some additional guidance about how we can conduct some of those more traditional high school activities, such as dances. We anticipate being able to hold prom with a test to sway protocol, where kids could come and get a test 48 hours in advance of the event, get a wristband, and their partner also get tested and be able to come to an event with on-school property. We're very excited about the data being monitored in this way, and then the protocols being flexible enough to adjust with the information that we're getting out of all these projects. So again, our profound appreciation to the HERO project.
Great, thank you. So as part of the HERO project, we've also been surveying businesses and individuals to make sure that we keep a pulse on the economic conditions of Utah. So one way we do that, you can go to the next slide, is we ask businesses what their revenues were this month relative to this time last year, and their expectations of their revenues over the next 3 months. And what we've done here is we've just graphed that. So the current revenues are on the horizontal axis, their expectations are on that vertical axis, and there are a couple key findings here. What you see is that COVID-19 continues to be an impact on businesses, and overall, revenues are down. But there is hope, and there is sort of higher expectations for the future coming off of this graph. And the other thing that to note is it's been very different by industry. Some industries, like food services, has clearly been hit much harder than other industries. So these are all important when we think about government policies that can help out these businesses. If you go to the next slide, one of the big policies at the federal level were these loans from the government to try to save jobs. And so we asked businesses about their employment situation, and what we find here, right? So in the graph here, we have layoffs as a percent of employees on the horizontal axis. We have a fraction of firms on the vertical axis, and that blue line is firms that received these PPP loans, and the dashed black line are firms that did not receive those loans or in similar situations, liquidity needs. What you can see is that government policy, the early evidence from this is that it did save jobs. And I think that's a very good thing to keep in mind as businesses try to sort of weather the storm here. If you go to the next slide, we also ask individuals about their income, their consumption, and their savings. Here, I give the income growth. We ask them, how do you think your income will change? And we ask this about yourself, about your friends, an average Utahn, and a average American. And there are a couple key points on this bar graph here. There is an increase in optimism from December to January. As you can see, for you personally, you start to see some hope of increasing income. You can see that for you and your friends and for Utah, the numbers are much more optimistic than for the US in general. And I think that really speaks to the Utah economy and how well we've been able to keep things going. And this is important, sort of just keep the pulse on this income, because income changes obviously lead also to spending changes and local economic growth in general. The final thing we do when we ask individuals is we try to get a sense of the risk that they perceive from this disease. So if you go to the next slide, what you'll see is a graph of the chance that individuals say they think they will catch COVID-19 over the next 2 months. So that's the percent on the horizontal axis, the chance they think that they will catch COVID-19. And again, on the vertical axis is the fraction. And I've graphed this for December survey and for January. And there are a couple striking things here. First, you can see that a lot of people believe that the chances of catching COVID-19 are very, very high, right? So there's a bump there at 50%. That's a 50% chance, okay? These perceptions really drive how people's mobility, how much they're willing to go out to stores, how much they're willing to engage in the economy. The other interesting thing in this graph is to see the change from December to January. And again, you see sort of an increased optimism here as people report that they believe that they have a lower chance of catching COVID-19, most likely due to increased news coverage and the rollout of the vaccine. And I think people's behavior and their beliefs of the chances of catching COVID-19 are integral to understanding the economic impacts of this pandemic. And to that point, I think it's important to understand vaccines, where we are and where we're going. And to that, I want to turn it over to Dr. Pavia.
Well, thank you, Nathan. So if I can have the next slide. My job is kind of to pull things together. We started with seroprevalence, and now we want to talk about, in the presence of vaccines and in the rapid changes that we're seeing in the virus itself, what is it really going to tell us? So we're going to look at the vaccine landscape, the variants. We're going to talk a little bit about herd immunity, what it really is, and how we're going to get to a point where we really have control of this virus. So on the next slide, this is some of the good news we've been hearing. If you look at the top at cases in Utah, there was a really steep decline beginning about halfway through January that has continued. And if you look at the bottom graph, you see the percent positivity in the yellow line for testing. Now, if you look very closely at the last couple of days, you'll notice that the rate of decrease is not as steep as it was. Something we need to keep a close eye on, because we really have a number of possible storms on the horizon that could disrupt the progress we're making. Next slide. The really amazing story of the beginning of this year has been the scientific successes of developing vaccines. You know, at the outset a year ago, it was unclear whether any vaccines would work. And now we have two vaccines that are being distributed under EUA that are extraordinarily successful, the mRNA vaccines. Measured against symptomatic disease, they reduce the incidence by 95%. But perhaps more importantly, if you look at severe disease, you get protection of about 89 to as much as 100%, which is what we really care about. On the next slide, you'll see that things are about to change and change for the better. The Johnson & Johnson vaccine is being reviewed by the FDA's VRBPAC as we speak. We expect them to give a favorable readout and to have approval over the weekend. This vaccine is kind of remarkable because it only requires a single dose. The overall effectiveness is slightly lower, but really not enough to make a big difference, 72% in the US, and 64% in South Africa, where many of the viruses were of a variant called B.1.351 that I'm going to come back to. But what's really important to remember about the J&J vaccine, aside from the fact that it's easy to handle, easy to distribute, works in a single dose, is that at 14 days, it's 85% protective against severe disease, and after 28 days, it's 100% protective. We expect the Nova vaccine, which has preliminary effectiveness in the high 80s, will also get approved sometime in the end of this month or early April. And at some point this year, the Oxford AstraZeneca vaccine will also probably become available in the United States. And both of these seem to be more effective against severe disease than they are against any symptomatic disease. Next slide. You know, one important question that we keep asking about the vaccines is how well do they prevent against asymptomatic infection and or shedding, which means, in effect, how well will a vaccinated person be protected from catching the virus and passing it on and promoting ongoing transmission. Here's what we know so far, and it's not a lot. In the first month, the Moderna vaccine reduced asymptomatic infection measured by PCR by about 66%, based on pretty small numbers. In another small trial, the Oxford AstraZeneca vaccine was reported to reduce asymptomatic acquisition of virus by PCR by about 67%. And then in data just released yesterday morning at about 5 a.m., the Johnson & Johnson Janssen vaccine reduced asymptomatic infection as measured by serology by about 65% over 71 days. Now, none of these studies actually looked at the ability to infect other people. They just looked at the ability to acquire asymptomatic infection, but we know that that is associated with a lot of transmission. So our limited data suggests that there is partial protection from asymptomatic infection, but it's a lower rate than what we see for protection against severe disease. Next slide. And we've done pretty well with the vaccine rollout in Utah. This shows the number of new people vaccinated by day. You can see a steady increase, averaging almost 15,000 before the supply was temporarily slowed by the presence of the severe storms across the US. And we expect it to go back up next week to the same levels. But we also expect that the vaccine supply is going to increase in March, and these numbers are going to continue to increase fairly quickly. As of today, about 660,000 Utahns have had their first dose, and almost 230,000 are fully vaccinated, which is, you know, really good news considering where we started from, but we have a long way to go. The other thing I want to point out, though, is that health disparities are showing up in vaccination as well as in infection. About 14% of non-Hispanic white people in Utah have received their first dose of vaccine, and this compares to 4.7% of Hispanic or Latinx. And some of this has to do with differences in age distribution. Some of this has to do with healthcare workers and teachers who are prioritized. But there is a lot of attention going on right now to make sure that we correct those health disparities. Next slide. Now I want to turn to the subject that has been really prominent in the news, which is the presence of variants. So this is, I think, widely misunderstood. You need to understand that all viruses mutate. They make mistakes as they copy their RNA. RNA viruses like SARS-CoV mutate a lot. And most of these mutations are meaningless. They lead to non-important variation because they don't confirm advantages. But as Darwin taught us, when there is selective pressure, a mutant or a variant that has an advantage will thrive, like the changes in the beaks of the finches in the Galapagos. And the more replication you have, the more uncontrolled spread of the virus you have, the more chance for evolution. There has been such an enormous worldwide surge in infections from November through January that there has been a real acceleration of the emergence and identification of these variants. Next slide. There'll be a test on this. Now, I'm just kidding. This is a table just summarizing the 5 mutants that have caught our attention the most, and I shouldn't be using the term mutants, variants. The one I just want to talk about for a second is the one on the far left, the B117, that was first identified in the UK. It has a large number of mutations, including the signature mutation at position 501 that confirms a significant increase in its transmissibility. Now, what viruses want to do to be fit, what gives them a selective advantage, is either being able to transmit more readily between people or to be able to escape from immunity that's either due to past infection or due to vaccine. And what we know so far is that the B117 is more transmissible. This virus that first emerged in South Africa is both somewhat more transmissible and more resistant to immunity from past infection or from vaccine. And that's true for several of the other mutants that I'm not going to talk about in detail. And just to remind you that this field's changing really quickly, just yesterday, the first paper on yet another variant that has emerged in the New York area that has both increased transmissibility and some suggestion of resistance to vaccine has been identified. Next slide. So what does this mean? It means that when you have greater transmission, a virus will become dominant in an area, and shown in the hot pink is the proportion of all infections in different countries due to the 117 variant as it emerged. And you can see a pattern that repeats itself over and over again. This variant has an advantage, it takes over. Next slide. This has been associated with a surge in infections. And I'm showing you here Israel, Portugal, and the United Kingdom, and Ireland. All of them were engaged in pretty rigorous control activities. Some of these countries were on lockdown, but as B117 became the predominant strain, they saw a big surge in cases. Now, they've been able to fortunately control this. And in all of these countries, that has required strict stay-at-home orders, levels we've not had to go to since March. Next slide. These variants are here in the United States, and we're just getting our surveillance up to speed. We do a pretty good job in Utah, but the US has been slow to accelerate. But as of yesterday, there are about 1,900 cases African variant that has resistance to some vaccines and a natural immunity has less of a foothold, but there've been 46 identified so far, but it varies by state. And South Carolina actually has a pretty significant outbreak of this variant. Next slide. If I can have the next slide. We seem to be having a problem advancing the slides. There we go. So let me tie all this together by talking about what we want to achieve, which is the level of immunity known as herd immunity, where the virus can no longer transmit in the population. When we reach that level of immunity, even people who can't be immune either from natural infection or vaccine or because of age are protected indirectly. And this level of immunity depends on how transmissible a virus is. SARS-CoV-2, the virus that causes COVID, is very transmissible. And we measure that by the R0 or the current transmission rate or the RT. There's a classical formula that's fairly simple, more complicated models. But what it tells us is that the more transmissible a virus, the more immunity you need for it to come under control in the community. What isn't often talked about, but Matt intimated this, is that even at much lower levels of immunity, 28, 30, 40%, you slow transmission, even though you don't eliminate it. On the next slide, we'll take a look at what the impact of a variant like 117 might be. It's going to increase transmissibility by about 50% based on our best available data, which means that the RT will increase by about 1.34 or 1.55 fold. And if it's 0.9 now, it will go back into the positive range as it spreads. Now, we're not even accounting for the fact that there may be some decrease in vaccine effectiveness due to these variants. That's an important concern. But what it means is our target for herd immunity in Utah is somewhere between 75 and 90%. That's the level at which we'll really have controlled this virus. Next slide. And there are a number of models. I won't spend time on this, but they suggest that as the more transmissible virus spreads, it won't delay when we reach herd immunity, but it will greatly increase the number of deaths unless we loosen up too soon, open up too soon, and decrease precautions, in which case there will be a fairly dramatic increase in the number of deaths, something we can ill afford. This one estimate, which is not gospel, suggests that the number of deaths in July could increase from 100,000 to 530,000 if 117 takes over and we have premature opening up of our restrictions. Next slide. So this is my last slide. Based on the data that Matt showed you, we estimate that around 600,000 or about 18% of Utahns are previously infected. It's not an exact estimate, but it's a pretty good ballpark. I also showed you that we have about 240,000 are fully immunized as of today, and partial immunity in another 460,000. But if we're going to reach herd immunity at a level of 75%, we need to have the combined immunity from natural infection and vaccine reach about 2.5 million Utahns. And that means we still have about 1.9 to 2.35 additional people who need to be vaccinated to get there. I'm sorry, we need about 1.6 to 2.5 million more vaccinated in order to reach the level that we are going to get to, that we need to get to using vaccine. Now, keep in mind that about 28% of the Utah population is less than 18. So we're really going to be at a disadvantage until we can start to immunize people who are 12 to 18. And hopefully we'll be able to do that in the range of June to August, depending on when the FDA approves data from the trials in teenagers. And next slide. So I just want to end with this and have questions, but the message is that speed is of the essence in our vaccination efforts because of the threat of the emergence of variants. The best way to reduce them is to reduce overall transmission. We are moving faster than we thought with vaccination, and there's a really good chance that that speed of vaccination will improve in the near future, both because of improved vaccine supply and the remarkable job that's being done getting vaccine into arms. But we need to continue to use masks, social distancing, reduce gathering size, and we need to continue to mask up so that we don't add any more flags that represent the 500,000 people who've died so far. And with that, I'll turn it back to Adam Looney for Q&A.
Thank you. I'm Adam Looney. I'm the Executive Director of the Mariner S. Eccles Institute at the University of Utah. And my role today is to help you find answers to the questions you've asked during the course of this webinar. And I will jump right in. The first questions are to Dr. Seymour. Case counts have clearly declined rapidly since January. And you said the reproductive number is less than 1. So does that mean that if things stay the same, the virus will go away and this downward trend will continue? And what are the risks to that forecast that you see? You're on mute.
Sorry about that. Yeah, that's a great question. Well, I mean, I guess the comment I would make is that the real-time reproduction number depends on our behavior and on social distancing. So I mean, so the key idea is that when the real-time reproductive number is less than 1, what that means is each new infectious case is infecting less than 1 additional person on average. And so, so reproductive number less than 1 doesn't mean that there's no more infections. It just means that the incidence of infection will decline, and the rate of decline will depend on what the number is. Now, the simple calculation of an overall number for the whole state does not really accurately represent all the places and patterns of transmission that are occurring. There's a lot of clustering of individuals, within households, within social venues, et cetera. And there are probably high-risk groups that are contributing to transmission to a greater extent. I mean, I saw there was another question about, I'm sorry if I'm misstepping my grounds here, but there's a question about the messages about low risk of serious illness in younger people, which is a very important and valid point. But younger people who have high infection rates may be contributing to infection in older people. And so it's the dynamics of contact, of social interactions that determines, the rate of new infections. And so, yeah, so the answer is, if we did not have the risk of escape mutants, if we did not have any worsening or loosening of social distancing, then my expectation is that things will continue to get better, as the vaccine-induced immunity increases. But as Dr. Pavia said, there's a risk of things not getting better because of loosening of social distancing or because of escape mutants. So that adds this element of unpredictability.
Thank you for that. Can I ask a couple of clarifying questions? One is, you use the term detection fraction. Can you tell us what that means?
Right. So, COVID-19 is a reportable disease, and everybody that has a positive diagnostic test for COVID-19 is reported to the state. That includes both asymptomatic individuals who have positive tests as well as symptomatic individuals. So the detection fraction is the proportion of the true number of infections that are reported, or it's a fraction of the true number of infections that are detected by clinical diagnosis or screening and surveillance. And so it reflects your ability to detect infections through contact tracing, through strong high access to testing, including screening of asymptomatic individuals who've been exposed.
Thank you. Dr. Hirsch, you said that basically 100% of schools in Utah are open. How unusual is that, and how significant an achievement do you think that is? What can other states learn from our experience, and what have we learned from other states?
Yeah, thank you it's a great question. It is rather unusual. There's only a handful of states in the country right now who who have virtually all the schools open in person. That doesn't mean that every student is attending school in person, but every student in our state has the opportunity to attend a public school in person. There's a handful of other neighboring states in the Western region that have very high percentages of public schools open for in-person learning. But overall, some of the states that have some of the highest percentage of public schools open tend to be lower population states, some of our surrounding states, Idaho, Wyoming, Montana, etc. Texas has a very high percentage of public schools open, nearly 100%. Florida in that range as well. I think it's very much an achievement that Utahns should be proud of. I mean, this began early in the summer with clearly prioritizing and plans for offering in-person learning throughout our state. Districts were provided the opportunity to make decisions locally. Every district in the state did open, save for one, Salt Lake City School District, which began the first half of the year in remote only, but is now offering in-person learning to all students at least a couple of days a week. I think there's a lot that other states are learning from our experience. Most importantly, the low rate of in-school transmission with adherence to mitigation strategies, most importantly, masking. The absence of large-scale outbreaks in classrooms. Again, when we reflect back to the summer, we saw large-scale outbreaks in congregate settings with youth, such as summer camps. This is a highly transmissible infection, but it's also a highly containable infection with mitigation strategies. When this, as time goes on, we're going to learn a lot by comparing the academic and social and emotional experiences of our youth to our peers throughout the country who haven't had the same opportunities for in-person learning and socializing that ours have had. So I think that we have really forged an important path nationally, and our peers throughout the country are going to be able to look to the experiences that we've had, the by and large successful experiences we've had with in-person learning, especially in our younger ages. We're learning from other states too. We've been kind of at the forefront with doing asymptomatic testing, but there's some other related innovative testing strategies happening in other states. For instance, things like test to play applied to entire schools, just simply testing everyone in the school every 1 or 2 weeks is the kind of thing that's happening. We're learning about other kinds of congregate activities from experiences in other states. And we're also learning, quite frankly, most of our schools, people have heard about the hybrid learning model and the hybrid learning models, which involves a combination of both in-person learning and remote learning. One thing that we have learned from other states is hybrid learning models don't seem to be associated with any benefits in terms of transmission. And it turns out that there's not really a whole lot gained by the sort of partial approach. And we really believe here that schools should be open, and they should be open kind of all the time.
That's great, thank you. And then we have a couple questions about what to expect from vaccines. One question is just about the supply. What's going to happen in the future about how many doses will be available and when we can have access to those. But a related question is, once we're vaccinated, what does that mean? When can we stop taking precautions, and when can we expect things to be more normal?
Thanks for those questions. So the supply is increasing, but it's hard to, you get projections from the companies as to what they're going to be able to distribute. Johnson & Johnson says that they will have 100 million doses by April, but there's so many things that can go wrong with vaccine production that you don't want to count on that. Pfizer recently promised a doubling of their supply. We know the supply is going to improve, but accurate projections more than 2 or 3 weeks out really are a fool's errand. But it is increasing faster than we expected it to. I think President Biden's projection that the most likely time for us to have enough vaccine for everyone who wants it is July is probably very achievable, and we might do better than that. What we can do in terms of what it's safe to do after you're vaccinated is going to depend on two things. It's going to depend on your being individually vaccinated, but it also depends on the level of the vaccination in the community, because you can still get infected if you're vaccinated, and how likely are you to come in contact with somebody who's not vaccinated, who's at high risk. And then it's going to depend on the level of transmission in the community. So the ideal point we want to get to is where 75 to 90% of the population are vaccinated and the numbers of new cases are very, very low. At that point, we'll be able to do most things the way we have in the past. But I think, as Dr. Fauci has said, is going to be a need to pay some attention to this virus, probably for the foreseeable future. And there will be situations in which masking is still going to make a lot of sense, and some activities which just may never be completely safe for highly vulnerable people. It's sort of a mixed message. I think the summer is going to look much, much better, but people who are hoping that things will magically one day return to the way they were before, that's probably not realistic.
Thank you for that. For Dr. Siegert, what do we know about the impact of individual prevention measures like masks or mask mandates on economic activity?
That's a great question. Thank you very much. We know quite a bit. So the way that mask wearing and other sort of preventive measures took place from a policy standpoint was very pocketed in the United States, typically left up to even counties. And so we can use a lot of that data, and we've analyzed that data to look at how that's affected mobility and spending data to look at what is that impact of things like mask mandates. And not surprising, and things that we see said in our surveys as well of individuals, is that people feel more confident going out to a store when there's a high level of mask wearing, right? That makes sense, right? If they feel like the risk is lower, if the risk is lower to doing some of these economic activities, then they're going to increase their participation in the economy. And that's overall a very good thing. And I think that's what we've really seen, is that consumer confidence has gone up as we've adhered more to these policies. And I think what you've heard from everybody else on the panel is, things are getting better, but this is not a point in which we want to throw away our masks. This is a point where we want to make sure that we follow through on what we've done to make sure, both from a health perspective, we save lives, but also that we keep our economy going strong.
Thanks for that, Dr. Siegert. And then just one last question, which is kind of a catch-all. Based on what we've learned from the HERO project about the transmission and incidence of this virus, what health measures and public health measures are most effective in that we should keep doing?
Well, I'll throw one thing out. There were, early on in the epidemic, there were major disparities by ethnic group and neighborhood. And focused efforts have really reduced those disparities. Data we just saw earlier today showed that in the January and December timeframe, there was much less of a racial and ethnic disparity in infection rates, hospitalization rates, and death. So focused efforts to reach out to communities experiencing high rates of infection really work. The other thing I think HERO has shown is sort of obvious. Masks really work. Social distancing really works. Matt just showed some data that probably supports other studies that suggest that restaurants are difficult to make safe in an indoor setting. And that we really need to pay more attention to how to make restaurants safe, at least until we can open up the doors and move the tables outside.
All right, well, thank you all. As there are some more questions, I want to thank the audience for watching. thank the Governor's Office of Management and Budget and the Utah Department of Health and the many participants in and partners in the HERO project for their help and collaboration. For the faculty and staff of the HERO project for their many months of hard work. And especially to the many individuals across Utah who have volunteered for this project and who are ultimately responsible for its success. Thank you and good afternoon.